Okay, thanks, Dr. Lindner. And I just want to say thank you to you and also Dr. Costi for inviting me to do this journal club. So I'm a psychiatrist over at Mayo Clinic in Rochester, Minnesota, and I'm an associate professor of psychiatry there. I'm the medical director for our mood disorders unit, and I'm also the co-director for our ketamine clinic. We run a small ketamine clinic that we've had for about 4 to 5 years now. I'm also the medical director for our TMS services, which we've had ever since 2009. I also do some ECT as well, not as much. So my specialty area is in mood disorders. And the journal club talk today I'll be going over is a recent publication that we had comparing IV ketamine with intranasal esketamine. So the driving force behind this paper and this research is my colleague, Dr. Balwinder Singh. And he may or may not be able to join us in about half an hour, but this is the study that he spearheaded and I was on as well. All right, let me go to the next slide here. Okay. And of course, let me know if something is not moving on the screen, but basically the idea of this study is we just want to compare how patients did at our clinic with IV ketamine versus the intranasal esketamine. So this was an observational study. These patients had already received ketamine, and then later on we went back and took a look, and the patients were between August 2017 to June 2021. For our inclusion criteria, it's a clinical clinic. So for IV ketamine, we did have an age of up to 65, mostly because in the literature, we've noticed that almost all the studies we see, they stop at age 65, so we did that. But for intranasal esketamine, there is no upper limit. So we've had patients who are older than 65 who come, and then we say, yes, let's do intranasal esketamine if that fits. And remember, for intranasal esketamine, in the US, the FDA approval is only for major depression. So if a patient came to us and they have bipolar disorder with the bipolar depression, we would say, no, we don't want to do intranasal esketamine, and then we would see if they would qualify for IV ketamine. Another thing is the BMI. We have a BMI cutoff of 40 for intravenous ketamine. And then for exclusion, we're actually quite strict with our exclusion. So if there's any history of psychotic symptoms, we'll say no, or schizophrenia or substance use, we'll say no. If the patient is on a lot of lorazepam equivalents, we'll also say no to that. Our infusion criteria, I think, is similar to probably what most everyone else has. It's a 0.5 milligram per kilogram over 40 minutes, but we do have a maximum weight of 100 kilograms that we would not give a dose higher than 50 milligrams, basically. Sometimes if patients had trouble tolerating this, we might run it over 60 minutes instead of 40. And we do have people hooked up to a cardiac monitor and pulse ox during the IV ketamine. They're on a gurney, and of course, no driving for the rest of the day. I won't read all the details on the slides here. We do have a stop criteria. If the blood pressure goes too high, above 180 systolic, we would stop. And in practice, I think we've only had to stop maybe 2 or 3 people. One of them was because of high blood pressure. Another 1 or 2 is because the patient didn't feel well enough, and we stopped. For the intranasal, there's only 2 dose forms that we use, 56 or the 84. In practice, one can actually give in 28 milligram increments because, of course, each bottle is 28 milligrams. So most of the patients we would start at 56 milligrams, and most of them we also finished at 84 milligrams. And patients complain of just a bitter taste when we give this. But otherwise, there's no monitoring needed except for just a regular blood pressure and pulse at 3 time points, baseline, 40 minutes, and at 2 hours afterwards. Okay. So the protocol for us, I think, again, this is pretty similar to what I see other people doing. 3 IV treatments over 2 weeks. This is for the IV ketamine. And in our previous experience, we felt that if a person did not respond after 3 treatments, the chances of them responding after that are pretty low. So we tell our patients up front, if you're not getting better after 3, we're going to stop if there's no significant improvement. Now for intranasal, we follow the guideline from the manufacturer, which is you got to do 2 treatments per week for 4 weeks, and then we see if they're feeling better. If they're feeling a lot better at the end of the acute course, so that's either, well, it's a combination of they have to tell us that, yes, this really helped, and also we look at rating scales. So we happen to use the QIDS depression rating scale. If that's greater than 50%, then we'll say, let's move you on to maintenance. Otherwise, we won't move you to maintenance. So I mentioned the QIDS. It's a 16-item self-rated scale, and we give this right before they get the treatment, and then we also give this rating scale about 24 hours after. Of course, they're at home, so many times the patients will forget to fill it out. And then it's a conundrum for us. We would like the data, but of course, if the patient forgets, well, we have to deal with it. And so in the study, what we did is if they forgot to fill it out the second day, we would impute the value for the statistical analysis. So it's a pretty standard statistical analysis with the univariate comparison, and then for many of the variables, and then mixed linear models. And we also did a Cox proportional hazard model to look at the number of treatments needed for response or remission. We also looked at what's the response and remission rates as well. So these are the baseline characteristics of our patients. So I've split it up into the IV group and the intranasal group. And a few things I'll point out. So this is a small study, 47 patients getting intravenous and then only 15 getting intranasal. So on the very right side, you'll see that most of these are non-significant differences. The age, the diagnoses, in the 2 groups, disability due to depression. There were some differences. One of them was the BMI, and I think that probably is because we selectively said if you have a high BMI, we don't want to give you IV ketamine. And then also the episode of duration in years. It seemed like the ones with intranasal had a higher number of years. And the baseline QIDS was around 17 to 19. We also looked at the comorbidities. So about over 60% of patients had anxiety disorders. I think that's very commonly seen in depression. Then PTSD is also another one. I think sometimes when we assess our patients, we don't pay a lot of attention to diagnosing PTSD. A lot of our patients have complex trauma, or they tell us about childhood trauma, and we may be missing formal diagnoses of PTSD, but anxiety disorder is certainly a large comorbidity. I'll point out fibromyalgia, chronic pain, and the other ones are less than 10%. We also looked at how many psychotropic medications they had in the current episode of depression, and of course, a lot of SSRIs, SNRIs. It runs the whole gamut. So these are the certain study variables and the outcomes. And I cherry-picked the ones which there were statistically significant differences between the IV and the intranasal. So I'll point out that the change in systolic blood pressure at 40 minutes, it seems like for the IV ketamine, that was certainly higher, about 8 points higher compared to baseline. And then at the end of the session, IV was also higher than the intranasal for the ending systolic blood pressure. Otherwise, the diastolic there was no difference between them. Change in the heart rate was a bit more for the IV ketamine. So these are kind of things that make sense. We would expect that. We had a dissociation score using the CADS, and there was no significant difference for that one. I put the baseline quids again, but the main numbers to look at here would be the overall response rate and remission rate. So we got about 58% response, 38% remission for the entire group. And this is kind of in the ballpark of things I've seen elsewhere in the literature. And then when we look at the difference between intravenous and intranasal, they're about the same. At least the response rate's about the same. The remission rate for IV, it's numerically more, but statistically, these were really the same. So this slide just shows you, if you're interested in all the other variables I didn't show you, that had no statistically significant difference between the IV and the intranasal. So pretty much all of them were the same. And then what we also did was we looked at in the response versus no response, is there anything that would differentiate a person doing better for response or remission? And the only thing we found was that if a patient had fibromyalgia or chronic pain, they basically responded. But of course, the sample size was really small, and there were only 7 patients who had fibromyalgia or chronic pain in our sample. So this is a graph of the change in the QID scores over the course of the treatment. So let's see, the red line is the intranasal, and you can see that the percentage improvement is not as good as the intravenous. But remember, in the end, we didn't think they were of any they were not different statistically. And then the other thing I'll point out is for the intravenous, remember, I was mentioning that we usually give our patients 3, and then optionally up to 6 treatments. So you see the intranasal, we always gave them 8 treatments. So this shows our analysis looking at the number of treatments needed to get to response or remission. So on the left side, you're going to see for response, you see that the IV, the number of treatments it took, well, median treatments was 2. And then for the intranasal, median treatments was 4. So it took longer to get to that point, and this was statistically significant. On the right-hand side, you'll see this is the remission rates. And again, intravenous, it took about 2 treatments to remission, and then for the intranasal, about 7 treatments. So remember, these are unadjusted. So then we use Cox proportional analysis, and then we use this to look at adjusted for sex, BMI, age, and also the baseline QID scores. So when we did that, I'll just tell you the punchline, which is basically on the remission side, the p-value was 0.051, so it's barely significant. Well, it's almost significantly significant. And then on the remission, it was statistically significant, p of 0.02 for the time it took to get to remission. So I'm going to summarize the main clinical findings here. The first one is really that the response and remission rates were really similar between the IV versus the intranasal. So that's the first main finding. And then the second main finding is when we're looking at the time or the number of treatments to response, it's faster, but not statistically significantly faster for the response, but for the remission it was. Okay, so those are the 2 main findings. So when you look at comparing this IV to intranasal, to me, a lot of times it's almost like comparing apples to oranges. So I've listed some of the major things here, and I think most of these you're familiar with. The one big thing is what's the absorption rate of intranasal esketamine. Different papers will say different things. We think maybe 45% seems reasonable. And I've mentioned already, for intranasal, we want to do 8 treatments. For intravenous, it's somewhere between 3 to 6 treatments. So these are the differences between IV and intranasal. So then how do we try to make this comparison more similar? So there's really no good way, but this was our attempt to try to look at the dose differences, because as you know, with intranasal, there's 56 milligrams and 84 milligrams. With IV, it's per body weight. Also for IV at our clinic, we mostly use 0.5 milligrams per kilogram. I know there's many other clinics that go up to 0.75 or even 1 milligram per kilogram. So what I'm trying to explain here is, let's say we take an 80 kilogram person, and if we use 0.5 milligram per kilogram, you get 40 milligrams is what you give. If we assume that intranasal has 45% absorption, then we will say it's 25 milligrams or 37 milligrams. So in our study, what we did was we used the number 45% of this dose, of the highest intranasal dose they receive. Usually they get up to 84 milligrams. We subtracted from what they would have gotten if they had IV, and then we looked at the mean differences and then divided our intranasal patients into 2 groups, either a high dose or low dose group. Keep in mind, we had only 15 intranasal patients. So then we did the analysis again, looking at the QID score changes. And when we did this, there was still no difference whether you got a high dose or low dose of the relatively of intranasal ketamine, esketamine. It didn't seem to make a difference either. So the limitations of our study, of course, sample size is pretty small. I've mentioned that. Also, QID scores. It turns out that we had 300 patient treatment combinations with the QID scores, and we really only had about 200. So 100 of the scores were imputed. Also, our study, we kept patients at 0.5. We weren't looking for dissociation when we were treating with patients. I mentioned that patients with fibromyalgia or chronic pain significantly got better than those without, but a small sample of patients who had chronic pain. All right, so what to make of this? Well, in our clinic, when patients come and if they're asking me, do I recommend IV or intranasal, based on the study that we did, and also a lot of other studies in the literature that we're seeing that are saying that IV is better than intranasal, I will tell patients, go with the IV as long as it's affordable. So remember, most places patients have to pay out of pocket for this, whereas for intranasal in the US, a lot of times it's covered by insurance. It's still expensive, but they have to do the math to see which one they want to do. Intravenous, we really think people do see a response faster. So that's also the other reason I go with intravenous. There was a recent systematic review and meta-analysis by Dr. Colleen Liu and her group, and that was published earlier this year. They looked at randomized controlled trials of both IV ketamine, esketamine, and including things like subcutaneous ketamine. And they divided into whether patients had high or low doses and whether it was racemic or esketamine. The way they defined their high dose, though, was that for racemic ketamine, as long as you got 0.5 milligrams per kilogram or higher, they called that high dose. So you have to keep that in mind. But they found effect sizes were the greatest for high dose racemic, and then moderate for high and low dose esketamine, and then modest for low dose racemic. So looking at that study is also saying that, okay, there's it seems like high dose IV ketamine still has the biggest effect size for the for single infusion. And then for repeated dosing and maintenance, they found that the racemic ketamine, whether it was high or low dose, was better than esketamine, either the high or low dose. So that is the summary of their study. So when I'm thinking about this, I'm thinking, well, so why is IV better than intranasal? I mean, the first thing I can think of is, well, IV, there's no worry about absorption. This is kind of the gold standard of treatment. So, so that might be the first reason I think of. For IV, people can also go to higher dosing. There's also dissociation. I think the current thinking is that dissociation is not associated with response, but there's always literature saying yes and then no. My other points about psychological impacts, I haven't heard many people talk about this, but this is something that I wonder about. So do patients come in, and then when you give a patient an IV medication, do they have this kind of feeling that, wow, you know, this is really powerful. I'm so depressed, I'm getting cannulated and I'm getting something dripped in me, versus I'm just taking a nasal spray or just taking a pill, oral medication. And then the other possible psychological thing is that, remember at our site, we tell people, if you're not better after 3, we're probably not going to do any more. So it's almost like I'm leading the patient on. Basically, they might be hearing me say, if you want this treatment and you're not better after 3, we're going to stop. So patients might kind of artificially feel better after 3 treatments, and that might inflate the response rates. Then I was wondering, IV has been around a lot more than IN. Is it because in the literature there's more sample size or more studies about intravenous? But then remember that the intranasal data is quite large because it's all from basically one site, Janssen. And this is really my last slide. So I was going to open it up to any other questions or discussion.
Thank you very much, Dr. Kung, for presenting such a wonderful presentation. I think it's got us all thinking about our own clinical practices, and for those just in the general knowledge and research space as to which one might be more effective for use. We do appreciate everyone writing their questions into the meeting chat, and we'll use these as our Q&A. One of the participants today is wondering, why did you use quids instead of Madras in your scoring, in your rating scales?
Sure. So, you know, I'm just going to pause and I'm going to introduce the first author and really the brains behind the study. So Dr. Balwinder Singh, my colleague from Mayo Clinic Rochester, has joined us. So, so I rely on Dr. Singh a lot. So Dr. Singh, our use, so I mean, one thing I'll say is that the QID score, of course, is a self-rating score. So that's easier to do compared to the MADRS. But I know, Balwinder, there were some studies that we did use MADRS as well, but for this one it was quids.
Thanks, Simon. My apologies, I joined a little bit late. I was actually seeing a patient who was getting esketamine for 6 months, and they're getting weekly treatment. So I'm a clinical researcher, so I wear 2 hats, one as a clinician and second as a ketamine researcher. So that's a great question. Why quids rather than MADRS? So the reason we use quids, it's patients can do it on their own. So it's a self-rating scale. So it's an observational study. If we use MADRS, we'll need additional IRB approval, additional clinical time, and additional funding to conduct the study. So it was an intentional decision to just stick with quids. There is data suggesting that the self-rating scale with quids can be easily interpretable or convertible to MADRS, or the change in quids is as significant as we see with MADRS. And that was one of the reasons why we used quids SR in our study. We do have a multi-center BioK open label clinical trial where we use MADRS. So what we do sometime, if we have patients who took part, let's say, in that research trial, and they found ketamine to be effective, and then they came to the ketamine clinic, there are ways we can convert MADRS score to QIDS or interchangeably. So there are papers published where we can do that. And we had, I think, 4 or 5 patients who were part of that research trial. It's an open label trial. Everyone knew what they're getting, but they had MADRS, so we converted their scores to QIDS. Sorry. So that was a long explanation for that question.
No, thank you very much. I think that is helpful. I do notice you also mentioned the tolerability between both being similar or equivalent. And I think one of the participants is also asking perhaps what percentage of participants may have withdrawn from the study after completing just the 3 sessions. And I suspect she's referring to the IV.
Yes, I think from a IV standpoint, so anyone who did not respond, they discontinued. So I think the 45% patients. Now, there are some financial aspects to IV. So we have, because IV, at least in the US, it's not, most insurances, they do not cover it. So each treatment ends up around somewhere between $600 to $800. So we have few patients who will get IV treatment, and if they find it effective, they would either end up switching to intranasal, or if they find it really effective, they may say, well, I cannot, if they can afford, they will continue to use, but they will slow down the rate, or or reduce the number or the frequency. I don't recall we reported exactly on how many discontinued for which particular reason, as the aim for this paper was just to kind of highlight the efficacy or compare the efficacy. Simon, do you have that number, Ben?
I don't have that number, but I was thinking about that just now. And in our paper, we didn't report on those because we were just focused on the ones who really completed, and then we could look at the data. But you know, that is a good point and a good question. There were only very few. I want to say out of the 62 patients, I'm thinking there were, well, if there were only like 3 patients, so that's still about 5%. But I'll make a comment, which is a lot of the patients come to us and then they're really motivated to try this. So they really get through this. And maybe also because we give 0.5 milligram per kilogram and we don't push it up, because it's when the dose is pushed up, it gets more uncomfortable, the dissociation. So maybe, and also we still use the same ondansetron if patients get nauseous or if they want it. So the dropout rate isn't very high for us.
Okay, thank you for that. And another audience member is asking, might this treatment be effective for chronic pain or fibromyalgia? I think they're alluding to the better response rates in patients with fibromyalgia that you reported.
Yeah, so it's an interesting finding that we had, but of course the sample size of 7 people out of 62 is small. I don't know how closely we actually tracked that the patient had pain or fibromyalgia, but usually patients will offer that up to us. So, you know, ketamine, of course, is used in the pain world for these kinds of pains. But my general impression is that the way we give ketamine, it's not that helpful for pain. But of course, our data suggests otherwise. So it's still something we need to explore more.
Yeah, I was wondering, you mentioned also that the higher BMI patients tended to be, I don't know, persuaded towards choosing the intranasal esketamine, and if maybe you could clarify some of the reasoning behind that.
Dr. Singh, can I ask you to answer this one?
Yeah, so that's a great point. And this, we made this decision based on a research study. So we did a couple of open label clinical trial with IV ketamine, and there was a consensus statement published. I think it was in American Journal of Psychiatry, and prior to that, it was published in JAMA. There was another paper published in JAMA Psychiatry. So we dosed based on their their body weight. We do not dose ketamine based on the ideal body weight. And so the concern with that is if someone with a higher BMI, they may end up getting a pretty high, we get some patients who are, let's say, weighing 160, 170 kilogram. They may end up requiring 80 milligram if we dose it half a milligram per kg body weight in an outpatient setting. And if for some reason they end up requiring, they're a higher risk of respiratory depression, or they end up requiring intubation, it will be very difficult, and the intubation might be tricky or challenging in an outpatient setting by the time the code team would be back. And so a decision was made based on, due to safety reasons, that anyone with a BMI, of 40 and above, that's where we drew the cap that, okay, for IV ketamine, our cutoff is BMI of 40. So it was more of a arbitrary cutoff, but looking at the safety. And then we talked with our anesthesiology colleagues, they were okay with that. And then the other change was anyone who was weighing more than 100 kilogram will cap that dose at 50 milligrams. So if someone is with a higher with a higher weight, but lower BMI than 40, then we would cap that ketamine dose at 50 milligram. That's the maximum dose we use for IV. So that was the rationale behind that.
And just to clarify, these were all induction phase, initial phase therapy patients. Did any of them go on to maintenance therapy? And perhaps, do you know anything about their remission rates?
Yeah. So, Simon, okay if I take that?
Yes, go ahead.
So
I
we
took it.
Yeah, so we are analyzing the long-term data. So most patients who remitted or responded during the induction phase or acute phase, they end up going to the maintenance phase. Now, what I would say, as we haven't published the paper, but I presented some of the initial results at a meeting, is that we are seeing a similar signal. Patients who were receiving IV ketamine, they require less number of treatments to maintain the response. And when I say maintain the response, they're not staying in remission. Most patients, they are staying in either in the response phase, or they will still have mild to moderate symptoms. So that's where our concern is when we are seeing someone with the chronic pain or other comorbid conditions where we feel they are kind of driving their depression symptoms. We kind of try to minimize the use of ketamine. And if there's a treatment refractory depression, then only we consider ketamine. But most patients, they ended up requiring maintenance treatment to have that response.
Thank you.
Let me add a comment to that. So we don't have as many esketamine patients, and one of my esketamine patients is a woman in her late 30s or early 40s, and for about 2 years she was getting esketamine every 2 weeks, and initially, of course, every week she would come in, and then later on, every time I bring up, hey, let's get you to every 2 weeks, she would start crying and she would say, I can't, this has helped me so much, I can't make it through. When I checked with the manufacturer, all of their data really says, give this esketamine every 1 or 2 weeks. They never really collected data on what happens to people who have anybody successfully taken esketamine every 3 weeks or every 4 weeks. So, the maintenance frequency is an interesting question for these treatments.
Yes, and just to clarify, presumably when you say esketamine, you're referring to intranasal esketamine and racemic IV ketamine, not IV esketamine.
Correct.
So we have another question here that they're wondering if there was a common reason why patients chose to receive either intravenous or intranasal treatment. I think you've touched upon this throughout the talk, and did it have something to do with affordability? And also, had any of your intranasal patients previously been treated with intravenous ketamine? So were they all ketamine naive, stratified to one of two groups, or had one migrated from one group to another, perhaps?
That's a very interesting question, because of our 62 patients, We have had maybe, was it around maybe four who did transition from one to the other. And Ballwinder, I don't remember in this study, did we treat them only as if they were, at the tail end or the beginning end?
So at the beginning end, so if they received IV ketamine first, then they were categorized under the IV ketamine group. And so regarding the question, IV versus intranasal, it's more about the affordability. As said, IV was not covered. So we see a lot of national patients sometime when they are, let's say, at Mayo for a week or two. They want to know if this is a drug for them, but they can pay out of pocket. So a lot of time it's the affordability issue.
Yeah, affordability, side effects, when I think about it, there were, because we definitely had one patient who felt the IV was too strong. The effects were too powerful. So then she did go down to the esketamine and she tolerated that better. And one patient just couldn't stand the kind of the bitterness, and one of them had more nasal irritation with the esketamine. So then we switched her over to IV ketamine.
And I think
Thank
I forgot, there was some question about IV, switching from IV to intranasal. We had sort of like a 50-50 response with that. We had a couple of patients who were, able to transition from IV to intranasal. But I think we had a couple when we switched from IV to intranasal, they didn't do as well. So one patient, I remember we had to go back to IV to kind of have that response.
Yeah, another member is asking that they're not sure if it was addressed, but what percentage of each group were on oral antidepressants?
I think pretty much 95 to 96. Everyone was on some form of antidepressant. There was maybe one patient I remember who had failed MAOI inhibitors. And I don't think that patient is in this paper. She's in the maintenance because she had failed MAOI and she thought none of them were effective, so she was only getting IV ketamine. But I think pretty much 95, if not 100%, I can double check, but pretty much everyone was on some antidepressant or other.
Yeah.
So I think people were also wondering about, we can maybe debate it in the formal or informal discussion about the sensitivity to the quids, but I did wonder, they asked about the benzo patients and why they were excluded, and if we have any more information about patients on benzodiazepines starting either IV or intranasal ketamine.
So I don't think we excluded anyone who was on benzo. We had a cutoff criteria that anyone who gets IV or intranasal, and that's based on our earlier work, that patients who require high dose of benzodiazepine, their efficacy to IV ketamine or racemic ketamine is much lower. So in our ketamine protocol, our requirement is that they have to be less than 4 milligram equivalent of lorazepam. So it was not necessarily an exclusion criteria, so they can still be on benzos, but we would usually request them not to take benzo before the infusion that day, and then they can have it the day or even after the infusion if they need to.
Yeah,
Something I've been, please.
I'll just add real quickly. So we have these neurobiologic or neurochemical reasons we think that the benzos are interfering with ketamine response. But for me, I also think about the psychological piece. So when a patient is on a lot of benzodiazepines, that tells me that anxiety is quite high, of course. And whenever anxiety is higher, I tend to think it's going to be harder to get some improvement with treatments in general. But
yeah. So the last question I have before we transition maybe to the informal discussion is, you mentioned all the medications the patient are on and lots of patient demographics, but I wonder if we know anything about the psychological support or therapies the patients might have been on whilst under intranasal or intravenous ketamine.
So we always recommend all the patients to still continue with their individual therapist. And most of the patients did have individual therapists. Some of them said, oh, I've tried at least a course of CBT or other therapy, and then they stopped temporarily. But you bring up a good point, which is I really believe that this treatment should be paired with psychological interventions, and especially to help with the past trauma events. I'll point out Dr. Lindner. I had a chance to visit his clinic, and you guys have this weekly group, kind of processing group for ketamine patients, and I think that's really an excellent idea to do so.
Well, thank you very much. I think it might be helpful for us just to take a pause from the recording and to take further questions informally. People are welcome to turn their cameras and microphones on, and we can follow up further. So thank you for the presentation.